Well, good afternoon, all. If you could give me a thumbs up, just let me know that you're hearing me okay. That would be good. Thank you. I appreciate it. So we're going to continue on with our spinal cord injury lecture series, talking about bowel management after spinal cord injury today. Basically, let's see if I can move forward now. There we go. So we're going to talk through what most of us learned without remembering. Although hopefully the memory has been enough where we usually don't have problems managing our bowels. We're going to talk today about the neuroanatomy, both of the intrinsic and the extrinsic nervous system, and then talk through the bowel anatomy, physiology, colonic reflexes, and then with regard to spinal cord injury, why defecation is different. So here we go. All of us are typically participating in food going in, fluids going in, and food and fluids going out through the gastrointestinal tract, whose purpose is to provide fluid and nutrients to the rest of the body. Typically, we take in somewhere around 800 grams of food and 1.2 to 1.5 liters of water on a daily basis. We secrete about 7 liters from salivary glands, stomach, gallbladder, pancreas, and intestines, and then reabsorb about 8.5 liters. So excretion is about 150 milligrams per day of fecal waste. Now we're going to talk through the bowel innervation and particularly recognizing influences from the intrinsic innervation, but as well the extrinsic innervation, how we control the intrinsic components through somatic, sympathetic, and parasympathetic influences. So the enteric nervous system, we have to recognize that like the heart, the gut has its own pacemaker cells. And within those different aspects of the gastrointestinal tract, we have pacemaker cells going off to allow for approximately 3 to 5 stomach contractions per minute, 10 to 12 duodenal contractions per minute, and then the colonic contractions, the pacemaker cells are much more variable, and so the colonic contractions are going to depend upon intrinsic as well as extrinsic influences to move along there. So you recall that within the colon, basically you've got the submucosal plexus, also known as the Meissner's plexus, and the myenteric plexus, also known as the Auerbach's plexus. And between the two of those, the contractions of the gut propel food forward, but also churn so that it's breaking it down as it propels basically fecal material as we get to the colon throughout the rest of the GI tract. So the extrinsic innervation, so in addition to having the intrinsic fluence at the enteric nervous system of the gut, we can control it externally through somatic nervous system. So we have control over the external anal sphincter and the pelvic floor musculature. But as well the sympathetic influences from the thoracolumbar tract. Remember that this gives rise to basically the superior and inferior mesenteric ganglion, T9 through T12, and then the hypogastric nerve, T12 to L3. Sympathetic nervous system influence on the gut is to reduce motility and secretions and to provide tonic internal anal sphincter influences. So the parasympathetic nervous system arises from the craniosacral axis. The cranial portions, basically the vagus nerve innervates to about the mid-transverse colon, and then you have the sacral parasympathetic influence from S2, S3, and S4 to the mid-transverse colon to the rectum. This is provided through the pelvic nerve. The parasympathetic influence on the GI tract is to increase motility of the colon and to relax the internal anal sphincter. So in general, we see under parasympathetic influence increased peristalsis and gut mobility, the stimulation of secretions and relaxation of the sphincters. So defecation, when you have an intact nervous system, is basically putting together physiological as well as psychosocial responses. So when we take in a meal and we extend the stomach, we get influences there that ultimately through the gastrocolic reflexes are going to stimulate propulsion of food through the colon down into the rectum. And usually within 30 to 60 minutes after a meal, we will see that gastrocolic reflex mediating a defecation response. So as the bolus moves into the rectal vault and basically expands the internal anal sphincter, it relaxes. And as it does that, if we need to maintain continence, have voluntary control over the external anal sphincter, the levator ani, and the Puborectalis. We're going to talk through those a little bit more as we go through this, so that we generally can make it to a socially appropriate place for defecation to occur, and it doesn't occur in the middle of a lecture, for example. So once we get into our space appropriately, we can relax the pelvic floor muscles, relax the puborectalis, and basically have stool expelled through the process as it goes through the internal and external anal sphincters. So one thing that we have to consider is that the puborectalis basically also helps us to maintain continence. And when the puborectalis is contracted, it prevents defecation along with the external anal sphincter. So if we're in a situation, as we see sometimes in the bladder with detrusor sphincter dysenergia, within the bowel you can have rectosphincter dysenergia. And basically what's happening is you have contraction and maintain contraction of the puborectalis muscle as well as the external anal sphincter. And if essentially this prevents defecation, although as it is spastic, it may relax at inappropriate times. And so you may have incontinence tied together with this. So let's go back through the colonic reflexes. Basically of the colonic reflex. And so as stool is being propelled through the colon, it actually causes a stretch and subsequently a reflex contraction that helps propel the stool forward. The gastrocolic reflex we talked about earlier. So as the stomach is stretched, basically it sends reflex impulses. Now these reflexes aren't like the knee-jerk response that we are typically associating with reflexes, in that the gastrocolic reflex again takes somewhere between 30 to 60 minutes to find its way all the way to the colon and cause the colon to contract. And so we can take advantage of the gastrocolic reflexes by timing our meals and in our bowel care program. We've also got the rectal colic reflex, and so within the rectal vault, you have receptors to both chemical or mechanical stimulation, and so we can take advantage of those as well. The anal rectal reflex is contributing to relaxation of the internal anal sphincter, and so in response to digital stimulation, for example. And then the bulbar cavernosus reflex isn't actually a portion of the bowel care program itself, but it tells us about the integrity of the peripheral nervous system and its ability to provide reflex, chemical and mechanical reflexes, and allow us to use those when we have an upper motor neuron bowel that we're talking about. So with spinal cord injury, we recognize that digestion and absorption within the GI tract remain intact, although colonic transport is somewhat slowed. Primary muscles maintaining continence include the internal anal sphincter under the influence of the hypogastric nerve for sympathetic influence, and pelvic nerve S2, 3, and 4 for parasympathetic influences. The external anal sphincter and the puborectalis levator ani are under somatic control, and therefore with spinal cord injury, we lose voluntary ability to contract those specific muscles. Also, we can't dampen reflexes, oftentimes related to this. And so this is going to contribute to bowel incontinence as we go through the process. Now, one of our major problems we've talked about, the number one cause of autonomic dysreflexia after spinal cord injury is number one, that is bladder issues. The number two cause of autonomic dysreflexia is number two, however, that is bowel issues. And you'll recall that Bowlby reported this syndrome as a massive sympathetic outflow in response to a noxious stimuli below the level of the injury in persons with spinal cord injury above T6. Complications of autonomic dysreflexia can include seizures, strokes, organ failure, and death under the worst case scenario. So what causes can contribute to autonomic dysreflexia? Well, certainly just a distended bowel, similarly as a distended bladder. But an ileus, constipation or diarrhea, acute abdomen, appendicitis, cholecystitis, cholelithiasis, ischemic bowel, hernia, trauma, cancer, all of these can contribute. They are essentially a noxious stimuli below the level of the injury. And so you have afferent influences arising from the gut that ascend the cord but are blocked at the level of the spinal cord injury. And you get this reflex sympathetic outflow that causes splanchnic vasoconstriction and subsequently hypertensive crisis. Increased pressure is sensed by baroreceptors that send information to the medulla, which subsequently sends information back to the heart and causes a reflex bradycardia. But below the level of the injury, you remain vasoconstricted. Above the level of the injury, you see sweating and vasodilation that we recognize as part of the symptoms of autonomic dysreflexia. So what are the goals of a bowel management program for spinal cord injury? Obviously, to have a predictable and thorough evacuation, one that is going to prevent incontinence. Ideally, we would like to control or make it completely not an issue, issues of constipation and diarrhea, and to prevent autonomic dysreflexia. Bowel continence, certainly the goal. Improved quality of life because of bowel continence, and then patient satisfaction physically, economically, and socially. And you say economically, what does that mean? Well, if you don't have control of your bowels, it's hard to maintain a job. I mean, potentially in the virtual workplace, that's not as big an issue. However, it continues to be an issue for our folks with spinal cord injury. And Kim Anderson, back in the day while she was still working with the Miami Project, reported out in 2004, what are the highest priorities for persons with a spinal cord injury? If they could fix something, which function would be most important? And those with tetraplegia, 10% of them said bowel and bladder. Those with paraplegia, almost 20% said bowel and bladder would be the most important things to get fixed if they could. So recently, the NIH, NIDLR, the National Institute of Disabilities Independent Living and Rehabilitation Research, and the Nielsen Foundation brought together a group of folks to talk about bowel management research, bladder management research, and sexual function in spinal cord injury. And basically put together preclinical outcome metrics that we felt would be important. So this is not yet clinical research, but it includes basic science and animal research, including assessment of the enteric nervous system through immunochemistry, fecal analysis, whole gut transit studies in the animal models, motility studies of the distal colon, and colonic smooth muscle tension recordings. With humans, however, objective metrics would include bowel diaries and laboratory findings, imaging studies, including abdominal CT and actual motion analysis of the defecation, endoscopy, colonoscopy, gastric emptying studies, including using wireless motility capsules to be able to check transit time within the gut, anal rectal manometry, so actually looking at the pressures within the gut, and then pudendal nerve conduction velocities, pelvic floor EMG as necessary. It was also important that folks be able to report what they're actually experiencing, and so subjective analysis with the Qualavine 30 or short form Qualavine and neurogenic bowel dysfunction scores. All are being recommended, and we're going to see, I think, a lot more research in this area over the next couple of years. So what are our acute upper motor neuron bowel management options? Basically, having folks upright on a padded commode if at all possible, otherwise left side lying in bed, which is suboptimal, but if that's all we can do, that's all we can do. Daily bicocodal suppositories and polyethylene glycol to be followed immediately by digital stimulation. That will last about 30 seconds every 10 to 15 minutes to up to 1 hour. And then documenting results in terms of the amount and the consistency of the stool. Ideally, this is going to be timed 30 minutes after a meal to take advantage of the gastrocolic reflex. For individuals with spinal cord injury above T6, documenting baseline heart rate and blood pressure after each digital stimulation is going to be important. And then follow the autonomic dysreflexia quick orders as necessary. Encourage abdominal massage and weight shifts after each digital stimulation. And once we are doing bowel care on a daily basis, but you have a day in which there is no stool but only mucus production, basically that tells us that we can decrease the frequency to every other day. Now, alternatives, if you have somebody who is having really robust responses in addition to autonomic dysreflexia, you may have to go with a milder form of bowel management. So using enemies, mini enemas, for example, or enemies plus, which includes a lidocaine component, could be helpful. Some folks are still getting autonomic dysreflexia even with that, and so a glycerin suppository may be appropriate. I really don't like the bicocodal and vegetable oil suppositories because it takes so long for them to melt. And generally speaking, you get an incomplete emptying as we look at that. So for lower motor neuron bowel management, we're going to be relegated to digital disimpaction. Again, ideally 30 minutes after a meal because you at least have the gastrocolic reflex still working. Again, having individuals upright on a padded commode if possible. This allows gravity to work with us instead of against us. Again, encouraging abdominal massage and weight shifts, and reporting out the results with regard to the amount and the consistency as we go through there. So bowel care equipment, we should recognize that depending upon a person's truncal stability, the padded commode system on the left may be appropriate. If a person has little in the way of truncal stability and mobility, so in other words, we're talking about folks with tetraplegia, you may have to go to the type of system on the right, which basically is going to maintain stability for them, but you can actually tilt them back and forth as you're going through this system. And then individuals may need reachers in order to do suppository insertion as they're going through the process. So we're going to talk through the management strategies for the upper motor neuron bowel in which we can take advantage of hyperreflexia as opposed to the lower motor neuron bowel, which is going to be hyporeflexic, and we won't have as many strategies to be able to move forward with. Obviously, the upper motor neuron bowel will respond to reflex evacuation, whereas the lower motor neuron bowel is going to be relegated to just passive evacuation as we go through the process. So with an upper motor neuron injury, basically you've got the final common pathway intact, so afferent influences to the cord, followed by basically alpha motor neurons to the colon and to sphincters as we go through there. Defecation after spinal cord injury is not voluntary unless you can take advantage of these reflex arcs. And so, again, having an individual upright on the commode optimizes gravity's effect, but it also optimizes the sphincter relaxation of particularly the external anal sphincter as you have the hips at 90 degrees going through there. Having a diet high in fiber is going to be necessary, but also as you do that, you have to provide appropriate fluids. And then we get into a balancing act between not having too much fluids where they end up having a distended bladder, and yet we're still looking for, with regard to bowels, a soft formed consistency for our stools. We'll use stool softeners and bulk forming agents as necessary to get there. We'll talk through those in a few minutes. And then using contact irritants, again, bisacodyl polyethylene glycol suppository and digital stimulation. Timing between 30 and 60 minutes after a meal to optimize the gastrocolic reflex, and then using Valsalva and manual disimpaction as necessary weight shifts. So we will start off doing this daily until the person becomes very regular, and then every other day as they are having mucus production without fecal material on the in-between days. So the digital stimulation that we talk about, again, is using the finger, gloved finger with lubricant, with a circular motion involving the wrist, gentle pressure to the bowel wall and the internal anal sphincter as you're doing this, approximately 20 to 30 seconds, and then repeating every 10 to 15 minutes up to an hour, using abdominal massage and weight shifts as necessary to ensure you get a full evacuation. One other point that's important to recognize: the bladder program should be preceded, the bowel program should be preceded by bladder management. So if you don't empty your bladder, then you're likely to be in a situation of autonomic dysreflexia with a distended bladder. That's going to stimulate this sympathetic outflow that is actually going to slow down the transit through the GI tract. And so always coach folks into doing their bladder program immediately before their bowel program, so that they're not fighting against the sympathetic nervous system as we go through this. On the other hand, the lower motor neuron bowel is not going to respond to either chemical or reflex, mechanical reflex stimulants. And so while the myenteric plexus is functional, we aren't going to be able to get these spinal cord mediated reflexes that we saw in the upper motor neuron bowel. The other thing is that you've got a denervated external anal sphincter with low tone. And so it's basically a flaccid sphincter, and things can easily slip out, for example, during transfers or pressure relief. And so as much as possible, we're going to be managing the lower motor neuron bowel on a daily basis to prevent anything moving through that flaccid sphincter. So that said, again, we would like folks upright on a commode if possible. Have a diet high in fiber as tolerated, with 2 to 3 liters of fluid so that you don't cause constipation. Now we're looking for a firm but not hard consistency stool. A firm stool is less likely to slip out through that denervated external anal sphincter. We'll use bulk forming agents as necessary to get the consistency right. Now you could use, but it wouldn't help, contact irritants and digital stimulation. So again, timing 30 to 60 minutes after a meal to optimize the gastrocolic reflex, and then using Valsalva and manual disimpaction, abdominal massage, and weight shifts for the individual to try to completely empty the bowel. This is one that you're going to almost always need to do daily in order to maintain continence, because again, now you've got a flaccid sphincter as we're looking through this. These are the things that we will look at, managing upper motor neuron versus the lower motor neuron versus mixed, as the case with conus medullaris may be. We also want to optimize activity. The more activity you have, the better GI transit that you get, and then try to maintain a schedule that is similar so that the bowel is used to responding at the same time on almost every day as we're going through this. Again, positioning seated is much better than sideline, but if you have to side lie, be on the left side rather than the right side. And you want to try to get the bowel care done within an hour. More than that is just taking way too much time, and the person's quality of life is going to suffer. If you're finding mucus with no fecal material, then the bowel care is typically going to be able to reduce the frequency, and then we're going to use medications as necessary. Recognize that this is one of the major problems for our folks with spinal cord injury, and so if they come in having problems with incontinence in particular, change one feature of the bowel care program at a time so that you know which feature is actually facilitating or preventing good bowel evacuation as we go through there. So with regard to the physical examination, as we talked about before, it's going to be important to know whether the person has an upper motor neuron or a lower motor neuron bowel. The best way to assess this is through the bulbocavernosus reflex, where you tug on the glans penis or the clitoris, or in lieu of that, you can actually just tug on the pubic hair while you have your finger inserted into the anal sphincter. You should feel, if the reflex is intact, a squeeze around your finger when you tug on the glands and or the pubic hair as you go through there. If you don't get a response, then the person is either in spinal shock or they have a lower motor neuron bowel that we're going to have to manage. So what works best? Fibrobulk agents basically are increasing the bulk by increasing water reabsorption, and so we can use things like Metamucil or Conceal. Generally speaking, those are a little bit more gritty and not as well tolerated as some of the other things that are available. So FiberCon, for example, or Benefiber can be helpful and generally speaking more tolerated. We recognize that we can also use stool softeners such as DOS, docosate sodium, or Surfact, which is docosate calcium. Neither one of these really enhance bowel transit or peristalsis, but they do help to soften the stool so long as the person is taking insufficient water. And then always with the bowel care, whether it's upper motor or lower motor neuron, make sure that you're using an appropriate lubricant so that you prevent injury to the rectal mucosa. So laxatives, we're going to try to use sparingly because basically these contribute to a lazy bowel. That is, the person becomes less and less responsive to chemical stimulation or mechanical stimulation that we're trying to utilize to get full evacuation. If you have to, you can use these, and I use them again sparingly. Mag citrate is one of those things that will help things move through very quickly. If you've had somebody with significant constipation and or ileus that you're concerned about, I usually start off with a half bottle of mag citrate, and again, using this sparingly. This is not a management technique. This is an emergency type of a scenario where we're trying to get the person back into normal bowel patterns. So the salts and or the sugars can be used generally, again, sparingly as you go through this. And then polyethylene glycol 3350 can be used. So this is basically PEG with Miralax or Go Lightly. And then finally, Senna. Senna is used early on in rehabilitation just to help get the bowel care program started. But I usually try to get folks off of it within 6 to 12 months after the spinal cord injury because known complications include melanosis coli, that is an atonic bowel with chronic use. And so trying to get people back into just using the bulk forming agents, the stool softeners, rather than relying on Senna is an ideal scenario. What about promotility agents? There are a number of things that have been used over the years and can promote motility, but oftentimes this is associated with undue side effects, and so we just have to recognize that this is going to be an issue. You know, anticholinesterase inhibitor like neostigmine has been shown to be helpful, but oftentimes associated with cardiopulmonary side effects. You can minimize those side effects by providing glycopyrrolate, which is a selective anticholinergic agent to be used in combination with neostigmine. There is some literature, but it's not. This is not one of those things that is promoted, so to speak, as we go through there. There are medications that have been available on the market. So the first one, tegaserod, basically has been withdrawn and is only available through certain research protocols at this time. Reglan or metoclopramide can be helpful and used as a prokinetic agent. But again, significant side effects associated with that, including extrapyramidal, so dystonias that go along with this, and sedation. Cisapride, again, has been withdrawn, typically because of the side effects, particularly increasing the QT interval and leading to torsades de pointes, which is suboptimal. And then more recently, the mu opioid receptor antagonists. So the methyl naltrexone, or Relistor, or naloxegol, basically can be used if you've got a problem with what you feel is opioid constipation. And then finally, erythromycin, surprisingly, can be used to stimulate motilin receptors in the upper GI tract. And this is kind of my fallback as we look through this. There's a great review by Kortson in 2018 if you want to read further about promotility agents. The contact irritants that we talk about, basically the bisacodyl suppository. Again, I don't like using the Docalax preparation. It's a vegetable oil base that takes about 3 hours to melt, as opposed to the Magic Bullet suppository, which is bisacodyl and a polyethylene glycol base and only takes about, usually about 30 minutes to completely melt, and therefore you get that full chemical exposure and the reflex response to that as well. The enemas that are available on the market, the enemies, contains doxysate sodium, polyethylene glycol, and glycerin. So it's a kinder and gentler preparation for those that are getting significant autonomic dysreflexia. I would consider switching over to enemies and or enemies plus, which includes benzocaine and again an analgesic to reduce the likelihood of autonomic dysreflexia as we're going through this. Fleets and soap suds enemas, again, used sparingly, not recommended for a consistent bowel care program. And then smog is a combination of saline, mineral oil, and glycerin, 50 cc's each in 1 liter preparation for an enema, again, used sparingly and not for routine care. Other management options for bowel cares, and this is both for upper motor neuron and lower motor neuron bowels. For those with intractable constipation and impaction or increased bowel time, consider using transanal irrigation. So this is a retrograde enema, basically the peristine system listed up on the top of the pictures here. Includes a rectal catheter, inflatable balloon, and then a manual pump as you're actually passing fluid in and then allowing it to flow out. You could also consider using surgical procedures. Colostomy typically is going to require the person's psychosocial acceptance of this. Recognizing that sometimes, so this is going to involve fecal diversion and potentially ileostomy. The Malone ACE procedure, ACE stands for antegrade continence enema, and this is actually where they use the appendix and essentially provide a continent catheterizable stoma to move this antegrade. So basically, you're flowing things from the appendix forwards, and was initially utilized in children with spina bifida myelomeningocele, and then later used with folks who have lower motor neuron bowel. Not as often seen in our adults with a spinal cord injury, although it depends on the area, and I need to find a surgeon here who is doing these procedures. I had actually a couple of surgeons while I was at Penn State, and a number of patients there who really felt like this gave them the best bowel care options, and those were particularly for folks who had been injured more than 15 or 20 years, and over time became less and less responsive to mechanical stimulants and chemical stimulants as we go through there. The bowel stimulation system, so the Vocare Bowel and Bladder, was commercially available in the 90s and around the turn of the century, but there just weren't enough users for this system. Again, this included literally a system that you could push a button and it would cause electrical stimulation and subsequently contraction of the rectal vaults and relaxation of the puborectalis and external anal sphincters. This is only available under research protocols at the moment in the United States. They have similar systems in Europe that have been used for some time. And the reason it didn't take hold basically was just because it's a relatively expensive system and there are relatively few end users, so to speak. Talking through the complications of neurogenic bowel for folks with spinal cord injury, we recognize that bloating and abdominal distension occur in more than half of our folks with spinal cord injury, whether that's upper motor neuron or lower motor neuron bowels. We can use simethicone to help to reduce this and to increase the frequency of the bowel care program. Almost 60% of folks will develop hemorrhoids, mostly because of prolonged sitting and digital stimulation. Hemorrhoidal cream generally can be of benefit. In some cases, the hemorrhoids actually stimulate autonomic dysreflexia, and under those circumstances, it's appropriate to surgically remove those with the hope that and knowledge that likely they will recur. So the person will get new hemorrhoids, but hopefully as that occurs, it doesn't, it's not as noxious as stimuli. And so that's a consideration. Fecal impaction occurs about 13% of our folks, particularly right colonic impaction with upper motor neurons and left colonic impaction with lower motor neuron bowel. Constipation occurs fairly frequently. And again, this is something that our folks typically will have problems with autonomic dysreflexia associated with this as well. So it's important to get things moving through. We recognize that one of the complications of constipation is in fact diarrhea. And so when you've got this abdominal distension, bloating, malaise, nausea, vomiting, and autonomic dysreflexia, this becomes a major problem. So obstipation is what we used to call it way back in the day. I think we still do. Recognize that clinical findings are including that abdominal firm abdomen, a KUB, where the gut is full of something, and you may require barium enema to be able to demonstrate this fully. So the treatment is volume resuscitation using a nasogastric tube, considering mag citrate or PEG 3350, and then progressive bowel care with bisacodyl polyethylene glycol, digital stimulations, and enemas as necessary. It may be also necessary to get a GI surgical consult, but most of the time we can, with gentle care, get past that. I mentioned that diarrhea is the constipation is the #1 cause of diarrhea for folks with spinal cord injury. And usually this reflects an inappropriate bowel care program. So this is important for folks who have been taking a lot of fiber and not enough fluids, can again become constipated, and then ultimately you have fluid just passing around the obstruction. So we recognize also that diarrhea could be in response to antibiotics because you're changing the flora within the gut. We worry about C. diff, colitis. Also recognizing that spicy foods and caffeine can stimulate diarrhea, and so incontinence as we go along with that. If the presentation is a bloody diarrhea, and you're not just British, but this is a bloody diarrhea, it's very likely tied to an infection of some sort. And so, again, those folks who present with fever, dehydration, and a bloody diarrhea need a full workup looking for parasites and potential infection within the gut. So the most serious complications that occur after spinal cord injury with regard to the GI tract include autonomic dysreflexia in over 40%. And again, we worry particularly about things like an abscess perforation. Superior mesenteric artery syndrome has been reported in a couple of case studies with spinal cord injury, and something that we need to recognize as well. Could be leading to autonomic dysreflexia. That might be our first thought as we go through this. And then we recognize that folks with injuries above T10 are going to be at higher risk for gallstones, as well as stomach and duodenal ulcers. About 60% of folks will develop gastroesophageal reflux disease. So obviously the psychosocial effects, particularly having bowel accidents in public, leads to a social paralysis where the person is just afraid to go out. And so this is a major issue, and our best prevention is education. And so helping folks to recognize why incontinence occurs, have them work with us in optimizing the bowel care program, and then in those relatively rare circumstances where nothing has worked, considering moving on to surgical management, colostomies, or the Malone ACE procedure, for example. So that was a pretty quick run through the GI tract and neurogenic bowel following spinal cord injury. I'm open for questions, comments, concerns. It's likely that you haven't seen much of this, at least on the inpatient side of things. But certainly in the outpatient setting, this is one of my major concerns for our folks with spinal cord injury. So open for questions, thoughts, concerns, gripes, groans. All right. Well, thank you very much. I hope everybody has a good day, and If you do have questions and you felt shy about just asking in front of everybody, feel free to shoot me an email, dgator@miami.edu. Everybody otherwise, have a great day.
I have a question.
Oh, yes, there is a question. Stephanie.
Yeah, sorry, I was trying to type it. I wanted to know a little bit more about those patients who are not able to do a Valsalva. You mentioned the lower motor neuron is sometimes used the Valsalva maneuver to help sort of get things going. If they're not able to do a Valsalva, then is it just digital stimulation that's the only option?
Well, they can still do abdominal massage. So working the way across the upper part of the abdomen and down the left side can be helpful. Weight shifts as well can be helpful as they're going through that, just to shift back and forth, in addition to providing pressure relief while they're sitting there waiting for something to happen. But that combination of things, and then they can attempt a Valsalva, but if they have abdominal muscle paralysis, just recognize that that may be somewhat limited. Again, to the extent possible, with an upper motor neuron bowel and even lower motor neuron bowel, by doing abdominal massage, you can actually stimulate the intrinsic nervous system to propel fecal material forward. So I think that sometimes we forget to use these mechanical things that are available to us. And so I just try to get folks to remember, if the person can do a Valsalva, great, that can be helpful. If they can do abdominal massage, if they can do pressure relief, and just weight shifts back and forth, that will help things move through during the bowel care program. Great question. All right, everybody have a great day. My gut feeling is you will.